Hello, my name is Sigurður Yngvi. I would like to thank the organizer for inviting me to present the data from the iStopMM study, which is a screening study for MGUS in the population of Iceland. iStopMM stands for Iceland Screens, Treats, or Prevents Multiple Myeloma. So we are unaware of the underlying causes of monoclonal gammopathies. We cannot predict which individuals with precursor states will progress to full-blown malignancy. There's no evidence from prospective studies to guide clinicians and patients for the optimal follow-up. And the impact of hereditary factors, genetics, imaging, and other molecular markers on transformation is unknown. And on top of that, all individuals with MGUS are identified out of pure coincidence because of another unrelated sickness, and this seriously impacts all prior studies. So the real question is, does follow-up for MGUS matter? So we looked at this in a very large study on 14,000 myeloma patients diagnosed in Sweden. So we looked at those that had been diagnosed with MGUS and compared with those without a prior diagnosis of MGUS. So let's bear in mind, we know that all myelomas are preceded by MGUS. Mostly they are not recognized. Sometimes they are, and they are usually followed. So here we are looking at the only difference between the two lines here is that someone knew that these individuals had MGUS. And we can see here that the overall survival is superior if you have myeloma preceded by a known MGUS. So I think follow-up is important. There are a few other studies showing similar results. Why is that? Is that because we identify them early and treat them earlier, or is it that we are leaning towards treating smoldering myeloma? This obviously is a matter of debate what to do, but there are some studies out there showing the benefit of early treatment in high-risk smoldering myeloma. Here is the Spanish trial, and here is a study where we looked at this in Sweden. We could see that the risk of myeloma going from high-risk smoldering myeloma is very high, and 50% had developed active myeloma in just a year and a half. So if we are talking about treating asymptomatic people, how do we find them? Well, either by chance or by screening. Those are the two options. We are looking at this in Iceland, the impact of screening. So the question we asked ourselves a few years ago is, should we screen for MGUS? So this is the outline of the iStopMM study. So we invited all Icelanders 40 years and older, 148,000 people, to join the study. When they had to do blood tests for other medical reasons, we obtained part of that serum sample and sent it to the binding site for protein electrophoresis and serum-free light chain analysis and IgG, IgA, and IgM. Those that had MGUS or a monoclonal gammopathy, they entered a randomized clinical trial with no further workup, the current recommendation from the International Myeloma Working Group, and the more intensive arm. Those without an M spike are followed without visiting our clinic. So the overall aims of the iStopMM is to evaluate the impact of screening for MGUS. Does that lead to an improvement in overall survival? We want to obtain evidence for the optimal workup and follow-up, what to do once we meet these individuals. Should we do bone marrow or shouldn't we? Should we do CT? Which tests should we order and how often? We want to improve the model, the risk model for progression by integrating other biological and imaging factors and germline genetics. And we want to evaluate the impact of screening on quality of life. We are doing intensive biobanking, and then also the whole scope of the iStopMM is early detection and early intervention. So we are evaluating the effect of that as well with a population-based treatment trial. So here's the recruitment, and this paper has just been accepted in Blood Cancer Journal. So we invited individuals to join us from November 2016 until October 2018. A total of 80,759 individuals gave informed consent, which is 55.4% of the target population. And now since last December 2020, we have received just over 75,000 serum samples for screening. So what we do is we follow all participants of the iStopMM, all 80,000, by cross-linking twice a year to the cancer registry. So we obtain all cancers from the beginning of cancer registry in 1956 and through the duration of the study. We also have a patient registry which registers all clinical diagnoses made all over Iceland, both outpatient and inpatient, from the beginning of the registry and through the remainder of the study. We check for vital status every 2 months. We have a prescription registry where all prescriptions done in Iceland are reported, and we get information on that, and then our quality of life assessment, which I will talk about in a minute. So these are just some examples of the registry data we have. We have information on 8 million primary care visits, 1.2 million outpatient clinic visits, 182,000 hospital admissions. We have 11,000 cancers in these 80,000 people. We have 17 million prescriptions. A very important part of the iStopMM is the evaluation of the psychological aspects of screening, because the literature is very sparse when it comes to the negative effects of screening on mental health. So this is what we do. We ask a lot of questions, lots of validated questionnaires that take quite some time, but we have very nice and high response rates. So people with MGUS have more than 90% of them respond to our repeated questionnaires, and those with MGUS have a very high response rate as well, 58.7%. So these are very super preliminary results. This is once we had analyzed 67,000 samples. So a little more males than females. We have IgG in 57%, 12% IgA and 22% IgM, and 9% are biclonal, which will of course be very interesting to look at further. The prevalence of MGUS, once we have analyzed 2/3 of the samples, is 4.3%, and this increases with age, as has been reported before, obviously. So we have already diagnosed 18 patients with active myeloma that have started treatment. We have 165 individuals with smoldering myeloma. We have 6 patients that have been diagnosed with CLL. We have 6 patients with Waldenström. We have 16 patients with smoldering Waldenström and 2 patients with mantle cell lymphoma. So the part that we are doing now and focusing on is the treatment protocol. So we opened a treatment trial in August 2019, and we offer all individuals with myeloma and smoldering myeloma to take part. We have already included 47 patients. KRD is the treatment of choice for 2 years in high-risk smoldering myeloma and active myeloma, and intermediate-risk smoldering myeloma receive Len-Dex for 2 years with steroids tapered off after 8 months. The plan is to include 80 patients. We do bone marrow at baseline and every 3 months for the first year, and then annually thereafter we do intensive biobanking. We have included in this project a flow project and quality of life assessment as well. So just to conclude, we have the iStopMM tree, if you will, which obviously has a lot of interesting possibilities to provide further knowledge on MGUS, risk factors for MGUS and for progression. I haven't mentioned the whole genetic part of the iStopMM and the mass spec, which is certainly very interesting. So we are going to look at renal amyloidosis and amyloidosis. We do cardiac echo of individuals with an M spike. We are looking at pain in these individuals. We are looking at the psychological impact. We're doing extensive tumor microenvironment studies. We're doing both germline genetics and somatic genetics. We are looking at neuropathy in the population. We are looking at the monoclonal gammopathy of renal significance. We are doing flow cytometry, mental health issues, different risk scores, obviously looking at survival in MGUS compared to non-MGUS, and We have measured immunoglobulins in the whole population, and we also have the mass spec project. So I would like to thank the organizer for inviting me here, our main sponsors and collaborators are the Black Swan Research Initiative, the IMF, the Binding Site, and Ulla Landgren in Miami. And we have several other important contributors as well. With that, I thank you all for your attention. Thank you.